Hello dear students. In today's video, we are going to discuss one of the most important topics of GI physiology, that is the GI movements. There are a lot of important concepts here, like what is the classification, how do GI motility is classified, and important motility like peristalsis, segmentation. All those can be individual questions also, or you can get as a long question also, and it will help you to understand some of the most common disorders which are relevant to the GI motility. So make sure that you watch this video completely, and if you have any doubts, kindly drop it in the comment section. I'll be happy to address your doubts. So let's get into the topic. Coming to GI motility, gastrointestinal motility, like the cardiovascular system also, when there is a motility that is happening, it is preceded by an electrical activity. First, there should be some electrical activity which generates the impulse, and then the further contraction will happen. So the basic electrical activity we have to understand. Followed by that, what are the different mechanical activity? So coming to the electrical activity in the GIT, it is called BER. What is this BER? BER is nothing but basal electrical rhythm. Basal electrical rhythm. So it is nothing but it is similar to the RMP. So RMP, we know there is a resting membrane potential in a cardiac tissue or a nervous tissue. In a similar way, there is some activity which is happening at the baseline. You can imagine it like a baseline RMP only. The potential at rest, it varies generally from minus 65 millivolt to minus 45 millivolt. So as you can see from here, it is a fluctuating type of movement. So there is constant fluctuation. So the membrane potential is moving up and down, up and down. And there is a pacemaker, just like we have it in the cardiovascular system. The SA node is the pacemaker. And in the respiratory system, we saw pre-Bötzinger complex as the pacemaker. Here in the GAT, the pacemaker is interstitial cells of Cajal. Interstitial cells of Cajal. Then the rate of BER varies according to various segments. The stomach, it is around 4 per minute. In the duodenum, it is maximum, that is 12 per minute. In the ileum, it is 8 per minute. In the cecum, it is 2 per minute. In the colon, it is 6 per minute. So this type of fluctuation or the baseline activity is continuously happening. But does this baseline activity sufficient to create a contraction? The answer is no. The potentials do not cause a contraction. They will be at the baseline, but you need some other add-on potentials like an impulse from the enteric nervous system or an impulse from the sympathetic system, parasympathetic system. Then the potentials can be generated. So that generation is called a spike potential. So if there is a good spike potential after the stimulation from acetylcholine, then there can be a contraction. So this spike potential is the one which is going to cause the contraction. So baseline activity is there over which the spike potential is going to come. The baseline activity is most of the time done with the help of sodium channels. Whereas the spike potential, the upward stroke in a spike and a downward stroke in a spike is there. The upward stroke in a spike, it is majorly contributed by calcium and some amount by sodium also. Whereas the depolarization or the downward stroke of the spike is by potassium efflux. Potassium efflux. So the upward stroke is by calcium, the downward spike is by potassium efflux. The potassium will move out. So let's see with the help of a diagram. So here they have compared the seconds, the timing along the x-axis, and along the y-axis they have seen the membrane potential. So the slow waves or the BER is there at the resting phase itself. And let's assume we are stimulating this particular region of the GAT with the help of acetylcholine. So I told you acetylcholine is going to stimulate because acetylcholine function is to rest and digest. So then it will develop a spike potential like this. If there is a spike potential, this is the electrical activity, followed by that there will be contraction. There will be contraction. So the depolarization is happening, contraction is happening. Whereas if it is stimulated by the sympathetic system, like the norepinephrine and epinephrine, what will happen? It will decrease the spike potential, it will decrease the basal electrical activity itself, and it will cause hyperpolarization. So this can lead on to decrease in contraction. So that's how this basal electrical activity and the spike potential are creating contraction or they are causing the relaxation. So next, coming to the physiological basis behind GI motility, which is the nervous system which is going to help. The myenteric plexus, which we have discussed in the first video, that is the myoenteric, it is going to cause the tone of the muscles. The rate and pattern, how much the contraction should happen and what is the pattern of contraction, all this will be determined by the sympathetic system and the parasympathetic system. Obviously, it will keep on modulating this motility. Then the parasympathetic system, through the cholinergic system, it will increase the tension in the GI muscles. Whereas the sympathetic system, they are going to decrease the tension in the GIT by the action of adrenergic. And when this motility is happening, it always happens in unidirection in a normal individual. For example, if there is some abnormality like vomiting, it can happen in a reverse direction. But generally, it happens from the oral cavity to the anal segment. This is also called as the law of gut. Law of gut means the movement of the motility of the GIT happens from the oral cavity and it keeps on progressing towards the anal canal. So this is called as law of gut. And why this is happening is the polarity of the GIT is designed in such a way that it starts from the oral cavity and followed by esophagus till the anal canal. The direction of polarity is from oral to the anal cavity. So this law is called as law of gut. So this is important. Next, coming to the mechanical motility. So we saw that one is the electrical activity. Now we are going to discuss the most important part, that is the mechanical activity. The mechanical activity, majority of the time we need mechanical activity in the GIT when we are having some food. So that is called as fed state. But interestingly, there are some motility which happens in a non-fed state. You are fasting, you are not taking the food, but some amount of motility is happening in the non-fed state, which is called as migratory motor complex. That is nothing but MMC. So in the fed state, there are two types of movement. One is called propulsive movement, another one is called non-propulsive movement. So in propulsive means propulsion. So from one part of the GIT, like A, it is going to move the bolus or the food to the next segment. That is called propulsive. It is moving from one segment and taking to the next segment. Whereas the next is called as non-propulsive. The food is going to stay in only one segment, but it is going to be churned and mixed so that digestion and absorption can happen. So that is called non-propulsive movement. So under the propulsive, we have peristalsis and mass movement. Under the non-propulsive, we have segmentation and haustration. This classification is very, very important. So mechanical activity, fed state, non-fed state. In the fed, propulsive, non-propulsive. In propulsive, we have the peristalsis and mass movement. In non-propulsive, it is the segmentation and haustration. In the non-fed state, it is a migratory motor complex. If they ask you which is the dominant motility in the GIT, if I ask you the question now, most of you will be answering it is peristalsis. The answer is wrong because peristalsis is propulsive. It moves from food from one segment to another segment. If it keeps on moving it as a dominant motility, what will happen? After eating, all the food will not be digested properly and absorption will not happen. If they ask you what is the dominant motility, it is the segmentation which is dominant motility. So I will just make a note here and we will discuss further on it. Dominant motility in the GIT is done by segmentation. Now let's go one by one. So first coming to the propulsive movement which happens in the fed state, that is the peristalsis. So how peristalsis happens is first that it needs a stimuli, either it could be a distension of the stomach. How it can happen? Either because of food or any irritation. So there is a bolus which is present and it is distending the stomach and stretching it. I will tell you a few important hormones. Please try to remember all of them. So at the site of stretch, suppose for example, this is the site where the stretch is happening. What is the neurotransmitter released? This is not given in many of the books, but this is very important neurotransmitter, that is serotonin. This is happening at the site of the stretch. Then the serotonin will go behind the bolus. Behind the bolus, what I have to do? I have to constrict it. It is causing a constriction. It is helping to cause constriction with the help of release of neurotransmitters. So constriction site is there. In the front, relaxation is happening. So constriction is happening with the help of acetylcholine and substance P. Whereas the front of the bolus, the same serotonin will go and stimulate the nerves over here to stimulate NO, nitric oxide, VIP, vasoactive intestinal peptide, and ATP. All of them will cause relaxation. So VIP is nothing but vasoactive intestinal peptide. So we have the serotonin. Behind the bolus, it is causing contraction. In front of the bolus, it is causing relaxation. Which neurotransmitters are causing contraction? Acetylcholine and substance P. Which neurotransmitters are causing relaxation? NO, VIP, and ATP. So this is the peristalsis. So it will help to move bolus from one segment to the another, like in the diagram. It is moving in a progressive way. Next, coming to another propulsive movement which happens in the colon region, that is called mass movement. It happens in a mass. The mass of the food is there and it is moving in a mass. So that's why it is called a mass movement. and it happens 3 to 5 times per day. It happens 3 to 4 times per day, and it happens the contractions over a large area. It moves the food inside, and many times there is one reflex which is very important. What happens is, whenever there is food in the stomach, sometimes we feel like as if we want to go to the restroom, like you want to empty your rectum. That happens because of a reflex which is called as gastro means stomach, colic reflex. Colic means colon. So food in the stomach will stimulate the colon and help in the movement and cause defecation. In adults, whenever you are in an environment, you eat food, but still if you feel like you want to go to the restroom, we will see all other things also, because our control on the on the bowel movement is superior. But in children, what happens is, when the baby is fed, immediately it will go for the potty. So what will happen? So this is because of the gastrocolic reflex. That is, baby generally what they do, they will just repeat this, and the parents will be really, sometimes they get annoyed also, eat shit, and the baby will repeat it. Why this is happening? Because of the gastrocolic reflex. The gastrocolic reflex, the baby cannot control it. It is not well controlled in an infant. That's why when they fed and the food reaches the stomach, they will immediately go for the restroom. So this is what happens in the infants. Now next, coming to the non-propulsive movement, I told you segmentation is one of the most important movement. It is a mixing movement. What happens here is, food bolus it at a point and force will be generated from all four sides. Why it should be the dominant motility is because it will help to break down the food and it will give time for the reabsorption. So it is helping in breakdown of food and time for reabsorption. So both the things happens in the segmentation process. Then coming to hostrations, in a similar way, it is happening in the large intestine, just like the mass movement. Here a bag-like structure will be formed, and that is called hostration. Here a large amount of water can be reabsorbed because of this hostration cycle that is formed, and it gives adequate time for the water reabsorption to happen, and it happens in the large intestine. So segmentation and hostrations, the food bolus will be in the particular segment. It is not getting propulsed from one place to another. That's why it's called non-propulsive movement. So all these things are happening when we are fed, but you have not taken the food. You have taken the food in the morning and you are directly taking the food in the afternoon. Is there any motility that is happening in between? The answer is yes. That is called interdigestive motility. Here the motility is not due to digestion. Here the stomach is empty. The GA is not having much of food, but still motility is happening. That happens in a non-fed state, which is called MMC, nothing but migratory motor complex. And it starts after 90 minutes of food intake, 90 minutes to 120 minutes. So that is why they say you have to leave your stomach empty in between two meals. It's not like you have to keep on snacking in between, because this MMC will help to clear the gut and prepare it for the next meal. And it will start when the stomach is empty, 90 minutes after taking the food or 120 minutes after taking the food. Then it will happen every 90 minutes once. But just in case if you snack something in between, what is going to happen? This MMC is going to be abolished. So let's see what is the importance of this MMC. It starts from the mid portion of the stomach and it goes till the end of the ileum. It is basically moving the waste. Suppose, for example, you have taken a meal and some amount of food is stuck up in the GAT. That will be swept away with the help of this migratory motor complex. And it not only sweeps or dry brooming is done, it will also pour the secretions like pancreatic secretion, gastric secretion. Here food is not there, but whatever chunks I have to take it or sweep it. So both it is doing. It is doing the dry brooming as well as it is pouring down water to wash off. So it is just like cleaning a room of a person. So that's why it is called housekeeper of the gut. And what is the hormone responsible? You can easily remember it. Migratory motor complex starts with M. The hormone is also M. So the hormone is motilin. So this can be asked in your MCQs also. And what is the cell which is secreting this motilin? It is produced by the MO cells. One of the time the question asked in AIIMS, they tricked the students telling that find out the false statement. One of the statement was motilin is secreted by M cells. M cells is different. Motilin is secreted by MO cells. So make sure to remember this fact. Then coming to this MMC, it happens in three phases. So the phase 1 will start after 90 minutes of food intake. Here the phase 1 is called quiescence. There is not much of movement. Here nothing is happening. Then after that slowly the phase 2 will start. The phase 2 there will be irregular contractions. So it is slightly moving the remnants of the waste product. In the phase 3 it is going to cause intense contractions. Here the food is not there. These movements are happening just to clear out the waste. So it happens in 3 phases: quiescence, irregular contraction and intense contractions. So just a small recap, the mechanical motility is generally classified into fed state and non-fed state. In fed, we have propulsive and non-propulsive. In non-fed, we have only MMC. In propulsive, we have the food is moving from one segment to another, that is peristalsis. Another one is mass movement. In non-propulsive, it is segmentation and hausturations. So make sure to remember this classification. It is very, very important. And all the things are very important. The hormones related to peristalsis and migratory motor complex. I hope this video is helpful. If you have any further doubts, kindly drop it in the comment section. And I am thinking to post some of the MCQs along with the video also. Try to answer them also. Thank you for watching the video. Stay tuned for more such videos. Thank you so much.